was retracted.
Actually, you can say that. Usually not a problem during MS. But classically, deep retractor with a curvature which can be adjusted and a hook used for retracting deeper structures, like if you're retracting the muscles, organs, or liver. I mean, you can also retract bladder with it. It's a multi-purpose retractor. Have you used it? Your answer should be yes. In which surgery you have most commonly used it? In which surgery have you used it more commonly? Most laparotomies are in the middle of the night trying to repair injuries. So laparotomies, then they'll ask you for what all you've done the laparotomies. Remember, instruments, specimens and x-rays are relevant only for those who are at the fag end of their exam and they have not done too well. So the examiner is trying to find some reason to learn something out of it. By identifying an instrument, you are not getting any mark. Everybody can identify a Devers retractor by this time. So they'll ask you, what did you do? Talk about the last surgery that you did. Okay, and you would say, I was involved in a splenectomy or repair of a diaphragmatic injury or colonic injury or whatever. So that would be the use. But the idea is it's a deep retractor. That's the idea. Devers. Very similar, but it's malleable. So what you can do is, you can give it a shape you want. You can give it an angle you want. You can actually make it straighter also. You can make it obtuse, acute, curved. You see, some people also use it for keeping the bowel out during APR. By putting it this way, they keep the bowel away. But it's usually with a wrap of gauze or cotton or something, so that you don't hurt. But this can keep the bowel in the upper part. Clear? Malleable retractor. Now this end can be used for hooking, this end can be used for holding, whichever end you want. Depending upon, if you want a deep retraction, you can hold this way. If you want a superficial retraction, you can hold it this way. So no big deal about it. Malleable metallic retractor. And the advantage of it being malleable is, you can give it a shape of a Devers. You can actually make a Devers out of this. You can make a leg and back out of this. You can also make a Morris out of this. So it's a malleable retractor. But I have used it, and I'm just trying to share with you that both ends are broad, and you can actually put the bowel up during pelvic surgery, especially APR, and it works very well because it fits into the abdominal wall. Slightly bigger, इनको side में there's no space for bowel to sneak through. Now the advantage of one broad side, the other narrow side, is depends where you want to use it. So it gives you that advantage also. So malleable metallic retractor. They are very similar, but this is broader than this, and it's got a curvature here. This is for a function. Langenbeck did the first cholecystectomy. It comes with that automatically. Now Langenbeck, when doing the first cholecystectomy, used it for retracting the part of liver which is where the bladder is, the gallbladder is, or the what you call as the plate. You would retract it, but he was constantly finding that it is not enough. Because what will happen with the retraction, the liver would keep falling like this. The part here, part here. So it did provide the space that it needed. Plus, it was narrow, so it could enter into the liver. Clear? Langenbeck's retractor. Now what is this hook for in all these retractors? This is to prevent it from slipping. You must have seen most people when they are retracting, they tend to keep it flat, which is the wrong way to retract. It should be hooked. The advantage of hooking is you stay out of the area, and number two, you are able to get some space to work. Now if you stay out of the area, the surgeon is able to, the person who is operating is able to see more. Against this background, his registrar Morris modified it, made it broader. If you look at it, it looks like a cousin brother who's eaten a little more. Broader, but there is a curvature here. Now this curvature allows for negotiation of the structure, the right angle or scissors. This doesn't. And this being broader, I'm sorry, I was telling you about this hook first. So you retract it, it doesn't slip away. If you're hooking, it won't slip away. If it was flat, and if you're hooking, it will injure. The other thing was you could keep a piece of gauze here and make it completely atraumatic and retract the lever. And if you look at it from that point of view, Morris becomes even smarter. Broad, so the entire thing is taken away. You got actually, if you watch it carefully, the gallbladder is here. I have retracted the liver away. Everything is very clearly visible. And mind this curvature. This allows you a complete look at the common bile duct, the part which is above the insertion of cystic duct. And the hook doubles up as something which will not slip, and secondly, you can put a pad. I tell you, my guide was invariably asking us to put a pad here. It was a routine, which also became the most important cause of gauze being left inside, and so it was abandoned. Liver was never retracted without a pad, which still is done. So these days we do it with a, you wrap either a abdominal swab or something, but it is a space for that. If somebody is asking you that question, you should know this answer. If he is not asking, don't worry. And on that day, don't try to give an answer which is not asked. Clear? Now the pad fits in here nicely, which protects the liver, and this hook allows it to stay, and the hook also allows you to take the liver out of the house. This is Morris and Langenbeck's. Morris is used for retracting the moderate kind of depths, but especially liver, rectus muscle, abdominal wall muscles. Now the back side, it has got the grip, which are fenestrations, broad ones. You can hold it like this. That is why the grip is. And what is this hole for? To make it lighter, which is the primary job. Don't say it's for the finger to be put inside. It's a wrong answer, but very commonly given answer. If a surgeon needs a finger to be inside a Morris to be able to retract it, you should not do surgery. It is not needed. You shouldn't get tired of holding it this way. This is the grip. Clear? Morris retract. Used for retracting liver, abdominal wall, deep structures, etc. Clear? Langenbeck's. See, the fenestrations have changed position. It is flattened. Because you don't need to apply so much of force. You just can hold it comfortably. Same function. You've seen it being used in retracting various superficial structures. It can't be retracting very deep structures. Journey spelt with C, and the hole inside is to make it lighter again. Don't give that answer. This is not good enough for finger. Just try to put your finger inside. It's a wrong answer. Don't put a finger inside it. It's to make the instrument lighter. That's it. Okay. Now, why have two hooks here and a flat blade here? Again, to make it lighter and to have a variety. Now, this hole, this space, allows for the needle to be seen as it comes out, especially when you are closing the rectus sheath, when you are doing the mask closure. Mask closure is done with a Jenkins technique, JANKIN', which you all do. What is Jenkins technique? Gopal?
Jenkins.
Jenkins. Okay.
Continuous single layer portion of the abdominal wall.
Anybody?
So suture should be, so there are two aspects to it. Suture should be at least 4 times the length of the incision.
Very good. First of all, the length of the suture should be 4 times the length of the incision. Next.
Sir, the bite should be taken 1 centimeter
away and not more than 1 centimeter from the previous bite. So 1 inch to 1. Third.
So the gap between the 2 subsequent bites should be.
I've already told you 1 into 1 centimeter. You're repeating. The first bite is the crucial bite. Now watch this here, rather than writing. This is the head end. This is the tail end. I'm retracting the rectus sheath. This entire stuff. The rectus sheath is the only thing left here. My first bite it inside out, outside in, at least 1 centimeter away and away from the last bite, the corner. I can't see the corner unless I have this. That is why it was devised. I am taking the needle inside out here. I'll come outside in here, so I need to see the needle, therefore this space. If I put it this way, watch it. Once the needle is gone inside, I can't see. I won't be able to rotate. But with this, I can. So I actually can take a bite beyond the incision. Is it clear?
Yes, sir.
Now, the needle would, this is a needle. Needle would come out here. I'll be able to see. Needle out, needle will enter here and come out here. I'll be able to see. That is why this. So the advantage of 2 blades, 2 hooks and 1 blade is, ये routine वाला है. Again a curvature, so that it doesn't slip away. Retraction means pulling and hooking. Pulling and hooking. किधर आ जाओ? Pulling and hooking. Okay. Now comes the space in between. It is to make it lighter. No confusion. Journey is done. This is the lung retractor. Don't bother about the name. Now look at its appearance. It has got a grip. You can't slip away. है ना, ये निकल नहीं सकते आप. But look here, it's very cleverly made. It goes up, down, and when you retract the lung, you'll be able to see still. Can you understand? This is used in thoracotomy when you're trying to reach the esophagus. Thoracotomy usually is right posterior lateral, and as you go through all the layers and you open the pleura, you go for the azygous vein, isn't it? Now when you're going for the azygous vein, this retractor is very handy. It has 3 major advantages. One is its location being, this is obtuse, this is acute. So what that does is, I have retracted the lung now and I am able to see clearly. Nothing blocks me. Secondly, this is light because of these wires, and this mesh allows the air-filled lung to expand in space. If it flat hoga, it will be traumatic. So air-filled bag. You want to puncture, don't want to puncture it. Clear? The grip is the key. You hold it in such a way that your hand doesn't go away, doesn't slip away. But retract it, you are able to see clearly. Is that okay? Now this is a lung retractor. That's all you need to know. Handle is strong. This is delicate. And this meshing is to allow for lung to expand, which is air-filled bag, and for you to see through it, because I can actually see much better if the angle is obtuse. अगर ये पूरा flat ऐसे होता मुझे दिखता नहीं. Clear? Can I move? This is joules, and joule is not joules. It is JOLL apostrophe S. What is Joul's triangle?
So Joe's triangle is you to see the external thyroid vein. We do the nidus maneuver. We pull the suprarachnoid wall medially and outwards and expose the space of reefs.
The moral of the story is, whenever you read a comic book, read it thoroughly, so that you don't change a hero into a villain and a villain to a hero. You read it, I know from where, but read it well. I've given it in my own book and also in the 10 Commandments. Pulling the lobe down and out. Down and out. Can't be in. Listen to me. This is down and out, you open up the angle, which is a space of reefs. And this triangle, one side is airway, other side is pole and the artery. This is called Joul's triangle. Joul's triangle contains external laryngeal nerve, not external jugular vein. And there is no external thyroid vein. Internal laryngeal nerve supplies what?
The sensory supply above the vocal cords.
Both are branches of? Which is a branch of? Given at what level? ये खत्म ही होता है, सिलसिला खत्म नहीं होता. निखिल? इतने परेशान होने की जरूरत नहीं. It's exactly a centimeter above where the superior thyroid artery comes out of external thyroid. And if you're not careful there, you can damage it when you're dealing with neck dissection. Anyway, ये आ गया. How many you lead in one case? 2. What is the limitation? Space. Joules. Okay. Now you would say mastoid retractor, which should be a wrong answer because you don't have any reason to have a mastoid retractor in your kitty. This is a self-retaining cat's paw. It's a cat's paw, but it is self-retaining, which doubles up as mastoid retractor. Because why should you have a mastoid retractor? And it is self-retaining on account of this lever. Here, this lever. So, if you want to make it function, used for superficial surgeries when you are alone. It gets rid of one assistant. So, self-retaining cat's paw or mastoid retractor, दोनों बोल देना so that you are safe. But superficial fascia muscle retraction. Some people, if you watch some videos, you've seen thyroidectomy also, they use it. The flaps they rotate, but that's a bigger one. I've seen one more which similar this thing, which is a spring action. ऐसे ही शक्ल का होता है, थोड़ा सा बड़ा, goes away. So that keeps the flaps quite far. It's very nice retractor. We use a rubber sling to retract the flaps, and we find that that's very effective. Causes less flap edema. Clear? So self-retaining cat's paw or mastoid retractor used for retracting superficial structures, and you can do without an assistant. Now, this one. Who's going to answer? Yes, Gopal. Why it is not a rib retractor? इतना बड़ा rib retractor नहीं चाहिए. So let's look at something where you have to go into the cavity that deep. It's a self-retaining bladder retractor. Used in the past for prostatectomy. Limbs होती है open. Use होता है ना. ऐसे खींच के करते हैं. Once you made an incision in the bladder, how do you recognize bladder? He'll ask you this question. That's why I'm asking you. When you're doing cystostomy, cystolithotomy, or prostatectomy, you make an incision in the midline, then you reflect the peritoneum, don't you? So how do you recognize the bladder has come? You are first. Are you answering? You're not answering. Okay, Deepak.
There are many superficial veins present.
One is veins, the bunch of plexus of veins. It is vesical plexus of veins.
And transverse ridges of the muscle is visible, white.
Very good. Transverse ridges of muscle are visible. Third
We aspirate urine.
Third is you put in a needle and aspirate urine. Don't put a knife before you've done these three. Clear? Now, after you made the incision in the bladder, watch it, what I'm showing. This end is towards the pubis. This is how the opening is, not this way. It's a favorite question of old examiners. ये head end है, ये foot end है. It's the wrong way to put it. This is the right way to put it. All retractors which are self-retaining are taking care of pelvis. This should go down where you are not going to see it. You should only see the bladder. Now once you retract, now this is the head end, the foot end. Now it is retracted and the bladder is visible to me. I will see the orifice. I'll look for the trigone and I can actually do the bladder neck release also by making an incision under vision, or I can actually go for prostatectomy. So this is some people call it Millen's self-retaining bladder retractor, but I am calling it simple self-retaining bladder retractor. Okay? This cannot be for the ribs. You don't need such a deep one. Anybody with doubt? You don't see it these days, that's why there is a doubt. This can be one assembly or it can be separate. Now what is it?
Ball flow stripe self-retaining abdominal retractor.
Along with doins it comes, which needs to be fitted into this, and you can actually use it for retracting the bladder. Even in hysterectomy, the same purpose. You basically use it for retracting the bladder. And the whole assembly is very effective, and you can actually do without one assistant definitely. The bladder goes down. Again, you would have seen that we put it wrongly in the abdomen. It comes on the chest wall, but actually it should not be in the field where you are working. That's the whole idea. Chest wall retractor भी एक था, हट गया क्या? If it is given individually to you, some people call it doins. We don't need doins, so you can call it a part of the self-retaining bell force, where you are retracting the bladder with this. Clear? This is an individual cat's paw. You saw a self-retaining. This is an individual cat's paw, which is used for retracting soft tissue fascia superficially. Okay? This is not a retractor used, wrongly used a single hook. It is not single hook retractor. It's a skin hook, which doubles up as a nerve hook or as a vascular hook. What will be the vascular use of this, Mandeep? What did I say? Nerve hook, skin hook, vascular hook. यहाँ पे एक slit है इसमें. This is for the grip, so that you stay away from the field. It is used for harvesting the 4 or 5 or sutures and keeping them all on the hook. You take a bite, putting it on the hook, because you can pull it at the end. All of them are on this, and they fan out like this actually when you hold it. And you release one, pull one, release one, pull one, release one, pull one. So this is used for vascular surgery also. It doubles up as a nerve hook. You can retract a nerve also with this, but not used anymore. Why? Because the angulation. Because it's a very thin thing. I use vein hook for retracting a nerve. क्यों भाई दीपक? Vein hook use करते हैं ना हम retract करने के लिए. तो कारण यही है. Broad, so it won't cause neuropraxia, angulation injury. With this, there is an angulation, but suture can be taken. You see, you're getting if you're getting all those sutures in the depth, lots of vascular sutures in the depth, we can use it for harvesting one by one. And actually, it's a very smart way to take multiple sutures, but they're kept loose on this, and you can actually take one out and make sure that you are able to close it adequately. The leaks are taken care of in vascular repair. Then nerve hook and also skin hook. और कुछ निकाल ले नहीं है ना कुछ, आगे चले. This, the moment you look at it, this is the depth for the chest. So it has to do with the ribs. Its shape, appearance, everything. It is to bring them together. If you reverse it, it can take them away also. But it's to bring them together for closing, approximation. So rib approximator. You getting it? After thoracotomy, if the rib is missing, you bring the other ribs together so that you can then put steel wire or proline or whatever you see now. This is how it works. And the curvature allows for the rib to fit in both sides. So you can actually cover up a defect of up to 2 ribs comfortably. So rib approximator. If I reverse it, it will be a rib spreader. दोनों तरफ hook उल्टे हो जाएंगे, it will go the other way around. Clear?
Yes.
Used for closing a thoracotomy by bringing the ribs together. Alright? नहीं है ना retract. Retractors are done. Line. Double hook. This has a space for finger. Retracting the superficial surfaces, skin, tendons, fascia, but tough structures because it's going to hurt. And it's been made lighter by giving slits in the center. This is a rib respiratory and it has serrations on both sides. Can you watch this? Which means the grip. You are supposed to hold it here. Which side respiratory is this? Hold it in your right hand. Hold it in any hand. This tip has to look at you. Presently it is looking at Nikhil. Left side. You should see the tip. Rib respiratory is a kind of a periosteum elevator for the rib because you can't go around the rib. This goes around the rib. So how do you introduce it? This is the rib. You will create some space subperiosteally. You see, the safest approach in bone is to go under the periosteum because there is no structure there. You will damage, if you go over the periosteum, you will damage the pleura, you can damage the other structures, the neurovascular bundle. So if you don't want to damage it, give a small incision in the periosteum and lift up the periosteum a little bit and then introduce this around.